This year, we are going to have Dr. Suresh Gupta Oration for the first time in Delhi Plastic Surgery Conference, and it is being delivered by Dr. Raja Sabapathy. Here is a brief citation about Dr. Raja Sabapathy. Dr. S. Raja Sabapathy is currently the chairman, Division of Plastic, Hand and Reconstructive Microsurgery, Ganga Hospital, Coimbatore, India. What started as a 17-bedded hospital in 1978 is now has developed into 650 beds with 38 operating theaters and catering to specialties in plastic, hand, trauma reconstruction and orthopedic surgery. Ganga Hospital, Coimbatore has values of good governance and its enforcement. It is one of the best centers for hand and microsurgery, not only in India, but all over the world. It provides training for excellency in hand and microsurgery, and trainees come from various parts of India and abroad. Dr. S. Raja Sabapathy has had a brilliant academic career, passing out as the best outgoing student from Stanley Medical College, Madras, standing first in medicine and surgery in the Madras University. Subsequently, he trained in Chennai, UK and USA. He has delivered 49 orations, chief amongst them being the Douglas Lamb Lecture at the Royal College of Surgeons, Bunzair Lecture at the South African Hand Society, Sushruta Guha Professorship of Royal College of Surgeons, Edinburgh, Pioneer Lecture of the British Society for Surgery of the Hand, International Guest Lecturer of the American Society for Surgery of the Hand, and Harold Kleinert Professorship of the University of Louisville. He has received 123 academic and distinguished awards, 400 international presentations, and 500 national presentations. He was conferred the Honorary Fellowship of the Royal College of Surgeons and Physicians of Glasgow, Royal College of Surgeons of England, Honorary FRCS England, and Honorary Fellowship, Honorary FACS of the American College of Surgeons, Honorary DSc from Dr. MGR Educational and Research Institute, Chennai, and Honorary Membership of British, South African Hand Societies and Serbian Microsurgery Society. He has been the visiting professor in Mayo Clinic, Yale University, Michigan University, Washington University, Singapore, Malaysia, Sri Lanka, and Bangladesh. He has co-authored a microsurgery practice manual, edited 2 books, and has published 244 papers and 61 book chapters. Ganga Hospital Microsurgery Training Lab is considered as one of the best in the world. 3,538 surgeons from 90 countries have visited this unit, a unique feat unmatched by any other unit in the country. At present, Sir is the president of the International Federation of Societies for Surgery of the Hand, IFSSH. He is immediate past president of the Asian Pacific Federation of Societies for Surgery of the Hand, APFFSH. He has held the presidencies of the Association of Plastic Surgeons of India, Indian Society for Surgery of the Hand, Indian Society for Reconstructive Microsurgery, and Brachial Plexus Group of India. He has been the organizing chairman of the Triennial Congress of the International Hand Surgery Congress 2013 and the World Microsurgery Congress 2015. Currently, he is the president of National Academy of Burns and the vice president of the Diabetic Foot Society of India. He has served as the editor of the Indian Journal of Plastic Surgery and editor-in-chief of the Journal of Hand Surgery Asia Pacific. He has headed many outreach programs in partnership with Rotary, Save the Working Hand, Help for the Hands in Need, for the hand surgery patients, and Project Hope for Fire, After Fire, a project to provide totally free reconstructive surgeries for the post-burn victims. 1,679 surgeries have been done in 928 patients with a project value of 13.39 crores, making it as one of the largest projects by a single team in the country. It is my privilege today to invite Dr. Raja Sabapathy to deliver the first Suresh Gupta oration. Sir, please.
I think I should really thank all the plastic surgeons of Delhi, and in particular Dr. Mahesh Mangal for giving me this opportunity to deliver the inaugural Dr. Suresh Gupta oration. I think one of the best memoirs about him has been written by Dr. Rajiv Ahuja, which was published in the Indian Journal of Plastic Surgery. I would recommend every young person to read this memoir which Rajiv Ahuja has written. I think it really, when you read it, you find that Suresh Gupta had many credits to him. And in those days, in the 60s, I think he was one of the few people who lived and trained for more than 5 years abroad and came back to India. I think if you really see all the plastic surgeons who have been trained in those periods, I think if anybody has been there for more than 3 or 4 years, they never came back. I think he's one of those people now who really came back. And he was one of the first persons to undertake microsurgery. In one occasion, when I was tracing the history of microsurgery, I really didn't put the time frame right. And when he came down, he called me, Raja, come here. I think you made the time frame wrong. And I did started it even before Venkat, he said me. I think that also tells how forthright he was, always correcting things and putting things in perspective. And he's been the first president of the Delhi chapter of plastic surgeons, and he was the first person to organize a real major international meeting in Delhi, in India. I think those of us who attended that meeting knew, I think, what a great meeting it was. It was inaugurated by the Prime Minister of India, and all the delegates were treated tea party at the Rashtrapati Bhavan. I think here is Gyani Jail Singh was the President of India. I think organizing a conference of magnitude is a colossal amount of effort, which I realized when I did the 2013 International Federation meeting in Delhi. At the time, again, I had to thank the Delhi and Delhi Plastic because my close friend Rakesh was almost a brother to me. He said he really helped in organizing this meeting. And it is organizing a meeting of this magnitude in times of 1980s. I think it really requires a lot of effort by a plastician. On a personal note, I am very indebted to Dr. Suresh Gupta. Because after I finished my plastic surgery, I was trying to go abroad, and I was finding it extremely difficult. I think it was in this meeting that I had the opportunity to meet Mr. Bailey. He was sitting under umbrella in this shade, and Dr. Venkateswamy introduced to me. And that turned out to be a turning point in my career. I think that's the way I went. I think I'm sure Suresh Gupta would have later realized that what an effort he was making could really mold the careers of many people. So that's the point when I was able to go back to Delhi, to go back to UK. And then from there, they sponsored me off to USA. And the sage of the Tamil poet used to say, help rendered at the right time, though small in measure, is greater than the whole world. I think what Suresh Gupta did for me, I think is really great. Along with Mahesh Mangal, we thought of what to speak for this meeting, and we decided on the topic of making progress in plastic surgery. So I'm not going to talk about how to make some incremental advances. I think if you are working in a Vedanta or Gangaram, I think how to make about 10% growth or 15% growth. But I thought of how do you radically change things for the better? I analyzed things in plastic surgery and also in other fields of walks of life, and I come up with some certain ideas. I do not know how many of you have read this article. It says Game Changers, published in PRS Go. Plastic and reconstructive surgery innovations in the last 100 years. I think they asked all the members of the American Association of Plastic Surgeons to rate. And they found the most important, the 5 top innovations. I think microsurgery topped the list, followed by the concept of flaps, tracheous craniofacial surgery, and then VAC, and organ transplantation. These are the 5 things which came up. And they also took it up by serially analyzed it, and the subspecialty wise. Again, microsurgery topped the list. And you will find that when you talk about surgical techniques, you find fat grafting, liposuction. And when you talk about consumables, then you find VAC, tissue expansion, breast implants. I think it goes on. All these things, stem cells, all this go on. But then after reading this, what I was thinking was whether India played a part in any of these major inventions. I think sadly it's not, and I leave it for you to decide. I think if you take any of them, I think whether India has played a great role, I think that's a thing which you really have to think. So at the same time, I also read an article about disruptive innovations and the concept of the second order. I think what was striking in that article was, which I also relate to plastic surgery, is that world-changing technologies usually begin as solutions to a surprisingly ordinary problem. I think there is one inventor, I think, is engrossed in particular one small problem which he wants to correct. And then he corrects that, but then the society takes it on to a different level. I think that's right. And then I thought I'll take it with the microsurgery itself. Fortunately, by God's grace, I had a great association with Dr. Bob Ackland. And then when he started, he had one idea, that is, He wanted to conquer the method of anastomosing more than a vessel of 1 millimeter in diameter. So that means you needed to make instruments and sutures. Now, I think all of us really don't think it's so easy. I think all of us do it. But then when you really think how it all started, they had a very, very great difficult time because they want to make an instrument which could hold a needle of such size. And you also have to make the needle of that size. You need to swatch the thread to that needle. And then when financially you will find, surprisingly, they were making needle holders and forceps smaller and smaller, thinner and thinner. But then as they did it, the problem was becoming more and more because it was a problem of controlling the tremor. And in fact, you will find that is so surprising to find Dr. Ackland was trying to use a foot control to control tremor. And they did it for 1 year. And then after that said it won't work. I did ask him about, I think, so when he was doing this, I think the voice doesn't come. I'll tell the voice what he said. He said, my friends, what Ackland said was, my friends were telling me that what I am trying to do is impossible. He said the word impossible has got one answer. That means you can't be bothered about to find out the obstacles for success. I think that's the message he said. I did ask Ackland, what do you think is the defining moment in microsurgery? He said the defining moment in microsurgery was finding out that the hand position to control tremor. 3 things stacked over there. And then said that made them think a different type of instrumentation. That's how the needle holders changed, the instruments changed, everything. This came to the development of the instruments of microsurgery. And he said this nice word, he said, the solution to a complex problem, when finally found, will appear to be very simple. I think they had worked for 3 or 4 years to find control tremor. And finally, at last, one day they just found out that by keeping it fingers stacked, I think then one over the other, you could control tremor. So that's what he said, the control to a complex problem, when finally found, will appear to be very simple. But then you need to make needles and sutures, and he said, I wanted to find a person who has the tools, and the tools to make the tools. So I went to Switzerland, and then I just put these all pictures taken from his article, and you also put all these pictures in the Indian Journal of Plastic Surgery, which you recently published. I think I would request every young person to go through this. Suppose if you think this is a needle, and you need to swatch the thread to the needle, and then what they did was you need to have a machine, and then which would exactly go to there. But then if you really think how it is difficult, they did that, and then they put in the thread, and then they had a block to close it. I think that's the way they really did it. And if you have to do it perfectly right, then what is really making it was, if only you make it exactly in the center, you'll be able to close it. And the needle size itself was about 0.075 millimeters. And the mistake that you could have is that of 0.002 millimeters. That means you need to strike it exactly right. And then anyway, we are doing the other way around. That means when it closed, I think it was breaking up. So I think that was the difficulty which they had. Now, equipments are there to do it automatically. But then the finalists had to do it. So needles which were of this size, they are becoming finer and finer. And we are able to make needles and sutures started getting lesser and lesser and lesser. If you see the characteristics of all these people who made it, I think they all had a growth-oriented mindset. They were obsessed with perfection. The most important was that they were all high levels of integrity. And all of them were willing to collaborate with people. I think they are all willing to collaborate with different categories of people. They are willing to collaborate with different specialties and industry. And effective execution was in the part. But then if you really find what did it achieve, I'm sure Dr. Ackland would not have thought what all microsurgery would have taken it up. We did replants, we did transplants, we did angiosomes, we did lymphatic surgeries, aesthetic surgery. I think everywhere, the microsurgery has come in. But then when he was trying to do the 1 millimeter vessel anastomosis, he was just doing that. But then really we do not know what all it will take it through. I think that's the way it should do that. But then there is a third step where India could do, because we missed it of making the innovations. One is that of making it available to the needy, or what I call as the democratization of healthcare. I think here India could introduce systems which could benefit the whole world. So if you read the history, I think in the article which I was reading, which was quoted as the order of the second order, usually they said all major inventions which really changed the world, there are 3 patterns they have. One, there is a problem, I think, which is a simple problem that somebody tries to solve it. There is a mechanism by which they solve it. And then the structural shift is that how the society takes it and takes it on. And they've given a lot of examples. I'll give it up in 5 examples. I'll give it to you. The first is the gunpowder. I think it is initially done to produce festival fireworks. But then when this festival fireworks went, somebody made it into a cannonball. Then once the cannons came, I think it really changed the European whole order. I think what they thought of stored castles, which is what impenetrable, I think they become nothing. And that is the one thing which made European colonialism possible. Our kings had horses and elephants, but then they had cannonball. I think it only led to the European colonization. The next was in Manchester and Liverpool, when they were in the coal mines, they were fined that they wanted to pump out the water from the coal mines, and somebody made it as small steam engines. But then once they understood the power of the steam, that thing, steel locomotives came and the industrial revolution came up. I think it just came up because of that invention. And then what really happened was the populations were uprooted from the fields to cities, never to return again. So that's the next thing, third example I like to give is the telegraph. Initially it was done to give point-to-point communication. And when it was invented, the first time people found that the information could be outran a horse. Previously it was the speed of information transmission was the horses and pigeons. But now they found out they could outrun a horse. But when it happened, nobody realized what will happen to the global markets or the modern financial trading. And the last two inventions, last few things I'll say much more interesting. You say there's a steel box which reshaped the world order. There's a containers. I think all of us have seen this container. Initially, this steel box was made by a person who really wanted to avoid theft when it is going. He just wanted to make a box and made a lock so that. But then when they made the lock, people realized that that could be loaded much more faster. I think more things could be kept. And once the steel box came, I think it really changed the whole order of supply chain. And then the West deindustrialized and Asia industrialized. They all because of just a steel box. And the last one I should say, I think all of us will say, I think the like button. It was made to quickly appreciate a friend's post. But then nobody realized that it would be a weaponization of attention. The dopamine loop and the political polarization are normalized, and the teen mental health crisis. But then what started off just as this thing, I think all because of a thumbs up icon. So really you will find that what we have to do is that we need to do something which is good and then take it in the right direction. It is said revolutions don't happen when society adopts new technologies. It happens when society adopts new behaviors. I think that's what is the main thing. And I was thinking that whether we have done something or anything where the sequence has been possible, and then what is that all of us should do this. I think that's the way to making real big progress if you have to make. Those of you who are young, I think should aspire for it. I think you just have to really think, is there anything is a burning problem that you have in your place? And then think of a solution. I think the seniors should encourage them and felicitate them should make it happen. I was just thinking our own experiences, what all we have done. I think what really made us shift from a 16-bed hospital, I think to a 650 beds, I think it was a few things that came up to my mind. One was the on-arrival block. I think here is Dr. Bhatt is giving the block. And this became it took about 25 years. And then Dr. Don Leonard, who visited us, and he said this has been written. And then, in fact, the whole summary was written by him. I think how did it start? I think when it is in 91, 92, when we started, we had a very small place. And then since we were extremely busy, that all the injuries that came in were all directly sent to the operating room. And there we find it in the small place, there are patients to be operated, some patients who had come for review, and some new patients, all were sitting in the small place. And when a new injury came, we just thought, if you opened the dressing, this fellow shouting, that was creating a problem. I think that was the only thing. We just wanted him not to keep shouting. And then he said, what if we give a block and then you open? I think that's it. I think that's the way the saga of the regional anesthesia started. So I gave a regional brachial plexus block and then opened a dressing. But then we realized that we established Ganga Hospital, one of the most acclaimed method of reception of trauma care, and in an enhanced patient centration. We didn't really think that if you give a block and then take an X-ray, I think that's an X-ray that is taken as he comes up with a bundle of bandages. And then after the block, I think you can really place the hand and then take the X-ray. I think it gives so much of a different view of how the X-ray is taken, and is so much it's comfortable. So it makes a structural shift because it becomes a center for regional anesthesia. So as of now, every year we have 84 post-MD anesthesiologist fellows we have, fellows of regional anesthesia. So 72 people come for 6 months and rest of them 1 year fellows. At any point of time, we have 98 post-MD anesthesiologists at our hospital. I think that's the one thing, which has made us do 100 surgeries a day, and then which has made us, helped us to become a quality trauma and reconstruction and orthopedic surgery center. But then if you really say, I think if you're really reflecting back, I think what makes it possible, it all started with a mundane, simple question. That is, we wanted to prevent a patient from shouting and crying when opening the dressing. I think that was the point which it came. But then if you have to really continue it, I think you really have to have the conviction that you have to do it, commitment. So once we started doing it, there was the one critical question which made it really possible. That is, Bhatt asked me, so what happens if after the block, he doesn't want surgery and wants to go to some other place? I think as we were just having a cup of coffee, he asked me this question. I said, if after coming here he wishes to leave us, then the only reason he should be for finance and non-affordability. That should be the only reason. Why should he go? In that case, I think we'll do the surgery free or whatever he affords. And then but we'll not miss this honorable block. I think we'll continue with this block. I think it was that decision which made it really possible. So in addition to that, what really made it was a system of variable pricing and system of paying, receiving no advance on arrival, and which really helped us to become a high volume, high quality, affordable care model. And then this was even studied by the Indian Institute of Management, Bangalore, and they wrote it up in the Harvard Business case study as to how this could be offered. So what I'm requesting is that now if you have, I'm sure all of us in our these things, you could think there will be some problem which is really pushing you down. And if you really have to think some idea as to how it has happened, and then persist on to do this. And Don Leonard wrote this book, wrote this letters. He said, honorable blocks were set up at Ganga Hospital, Coimbatore, India during the early 90s by the anesthesiologist Ravindra Bhatt and the plastic surgeon Raj Subhavati, out of necessity, who recognized its value and made it the standard of care. So we can make noticeable progress at all stages, and I will give you 2 examples. I think I'll share 2 examples, and then I think it must start in our hospital. I think it can easily start with you. And opportunities do exist for plastic surgeons to make a big thing, big thrust. But then many times we lose it. I think we lose it for not taking up that initiative. I'll give you 2 examples. I'll give it to you. And then I'll leave it for your thought. One of the times, now all of us agree that we have made a diabetic foot as a big thing. So I think we led the way, and then every time in every meeting now I find there are invitations to talk about diabetic foot, offloading surgeries. Just about 10 years ago, I'm sure none of us were talking about offloading surgeries. I think all of us were talking. It all arose because in one clinic day I had a patient who had a gracilis free flap to the heel. And he'd come back with an ulcer. I said, I got fed up. I think because it's not only it's frustrating for the patient, I think it's frustrating for you too. Because he comes back with an ulcer. I said we had to put somehow we had to put an end to this problem, and we need to read about it. I think we do it. I said, let's purchase every book that has been published on this subject and let's read. I think that's how we thought. We have not done anything original. I think what we did was only finding out what has been written and collating it and finding out how to make it useful. See, for us, the first order is the point is preventing recurrence of ulcers after doing a flap. So it's like this, and then 1 year it's fine, but then you find that 2 years later, now he comes back with an ulcer. I think it's not a great situation for us. Here again you find, you got ulcer, you do a fancy flap, it heals, and then 1 year it remains healed. But then when they come at 2 years, again, the same type of ulcer he has got. So after this, now we decided that in addition to treating the ulcer, we need to treat the cause. I think that means you need to take off the pressure points, so you need to do the offloading surgeries. I think that's how this article was written. And then we did classify these. So, but then we found once we started doing things, we thought that we'll get a lot of patients at the early point where we could do offloading surgeries and prevent their progress. That's what we thought. But then what really happened was, as your reputation grew, I think you are only getting patients who are class 3 and class 4, which are bad. I think we are getting people with high comorbidity. But then if we have to operate these patients with high comorbidity, that means they are all anesthetically very poor risk. So once again, what really happened was, one limb anesthesia came up, regional blocks that they picked up. And then our intensive care, intensivists were loaded with this type of patients. That then intensive care, I think that again found with them. So now it becomes a recognition of a subspecialty of plastic surgery. But then what we didn't think was happened. Then once we had talked, I think the government took over. I think the government of Tamil Nadu, I think they thought it's a good thing. The Secretary of Health, and then they understood, and the message reached them, and they entered into MOU with us. They said it has to be done for the whole of the state. I think that was called as the Padam Padagopam Thittam, which means the Save the Food campaign. Here we have with the Health Minister, Health Secretary, and National Health Mission directors, all of them. It was a MOU was signed for a capacity building for the government doctors of the whole of the state. And this project was presented at the Nitya Yog. And then it was well to skepticism, and then said, why don't you try it out on one district? I think they asked us to do this by one district. And they chose Tanjavur as the district. And for 1 year, I think what we did was surgeons from Ganga Hospital, I think we visited Tanjore. And for a day, live surgical demonstration. Every third Thursday, every third Sunday we used to go. Or every Thursday we used to go. I think the government deputed surgeons from all the medical colleges and district hospitals for that meeting. And the government was really kind enough. And they also told all the multipurpose health workers from everywhere to come to Ganga to teach. I think this is a busy slide. I just put the assessment. I think I'll tell you what really happened. In one district, we found there were about more than 170,000 diabetics. And then 98% of them were screened. I think we method found how to screen them. And we found the lower part, the last two lines you see, the minor ulcers, we had 3,000. And major ulcers were 1,046. That means in one district you have 4,000 people to be operated. So we find a solution, but every time you find a solution, it leaves a vacuum. That means whether you are willing to fill up that vacuum is the counts. But then the plastic department didn't rise up. I think they have to really rise up to the occasion to fill up that. Otherwise, somebody else will fill up that time. That means what are the prime requirements for that? See, one is the aptitude. And the second is upskilling. I think the upskilling part of it, we are not willing to do. I think that's one of the things, which plastic surgeons have to do. Because now there are diabetic foot fellowships are there. And the entrance for the diabetic foot fellowship is an MS General Surgery or MSCMC is plastic surgery. But if you really see, who will be better off? Will a MS General Surgery patient who has taken a 1 year concentrated diabetic foot fellowship versus an MCH plastic surgeon comes out to any center, then automatically you will find that 1 year fellow who has taken a diabetic foot fellowship is good. But then, if an MCH fellow takes up that 1 year fellowship, he will go far beyond. Because not only he can do offloading surgeries, all that, but then he can do flaps and microsurgery into that. So, but then if you are not willing to take that, upskilling that part of it, that 1 year fellowship, postdoctoral fellowship you are not going to take, that means we will lose out. I think that's the point number one. So it's all said, a revolution doesn't happen when society adopts new technologies. It happened when society adopts new behaviors. I think unless we take up these new behaviors, I think that will not happen. So making progress in plastic surgery requires one answering one question which is bothering you or your department. I think that's one. And second is that of taking structured post-MCH training. And we should be willing to fill up the vacuum. I think every time you find a solution, it becomes a vacuum. And then if you are not filling up the vacuum. But then here comes the question, that whether we will go to read or subspecialty is coming up and all this. But I think this is standard. I think nobody can question this because we cannot ring fence ourselves, nor can we ring fence knowledge. If you are not going to teach, you are going to learn it from other places. At least if you teach them, I think they'll have respect for you. I think that's it. There's no line. I think because in this era, you can't ring fence knowledge. I'll also take up the cleft lip story. So when we are trainees, I'm sure Karun also will agree, Then when we are all trainees, the whole clefts were treated only by plastic surgeons, right, Karun? Only where plastic surgeons were treated. And then most of the plastic surgeons were concentrating only on the surgery. And Smile Train entered and he found a comprehensive care firm came. And then if you find, I just took it from the web, they have done 750,000 surgeries they have helped to do. And around 40,000 surgeries are done every year. But then if you really have to see, reflecting back, I wonder if the plastic surgery university embraced comprehensive cleft work in those times and risen up to the demands of the numbers, we could retain the supremacy and held on. Because when the Smile Train came, I know of some surgeons who operated about 300 to 400 surgeries in a month. So that means there is so much of need was there left in the society which we didn't fill up. So there is a vacuum. I think we didn't rise up to fill it. Then somebody else fills it. So I think that's what we have to do. I think not say that somebody encroaching and all. Even now the young person, I think those of you who are young, I will only think when there are challenges that are there, I just ask you to ask a question. How will it enable me instead of thinking, how will it affect me? I think we need to really ask this question. I think this question has to be asked not only by the younger people, but also be asked by the senior people. I think there are certain rules that we have are, one, the solutions that we provide, I think the solutions always provide a vacuum and must be really ready to fill it up. If the speed of adoption is slow, I think it's lethal. I think you can take it in any industry. I think the cardiac, I think initially when cardiac catheterization came, the surgeons thought it was not worthwhile doing it. I think they gave it to the cardiologist. They gave it to the reluctant cardiologists. But then now you find, where is the interventional cardiologist gone? I think it was initially left for the surgeon. I think the surgeons thought it was below their dignity to do this. I think they lost it. If you are nearsighted, we are usually nearsighted to see the small inventions where the small inventions will lead us. I think we need to be farsighted. Don't ask if you'll be replaced. Ask how it will enable you to perform better. I think if you really see Dr. Suresh Gupta, I think even if you read that article, you will find people like Suresh Gupta who lived in the 60s and 70s. I think they all had a growth-oriented mindset. They had a high level of drive and resilience, creative and strategic thinking, and integrity and collaboration. I think most important is collaboration, okay, and effective execution. I also say that every person who has lived in the period, I think they must all be evaluated in the correct perspective of those times. I think you can't be evaluating a person historically. I think it has to be evaluated in the period in which the time they lived and they worked. I think if you really do that, I think they all score very high. The leaders, surgeons like Suresh Gupta have been great enablers. I think I should really thank because of his meeting I went abroad. So they have been great enablers. And while we honor him today, I think we need to remember the good work they did and the good principles he lived and taught us. I should really thank all the Delhi plastic surgeons for giving me this honor of delivering the inaugural Dr. Suresh Gupta Oration. Thank you so much, all of you.
Thank you so much, sir, for the wonderful oration. Your words were truly inspiring. Now I would like to call upon stage Dr. Anubhav Gupta and Dr. Mahesh Mangal to present sir with the citation. I would like to invite on stage Dr. R.K. Srivastav to present Sabapati sir with a shawl. I would like to invite on stage Colonel Omkar Singh to present sir with a plaque. I would like to invite on stage Dr. Bhim Singh Nanda to present Sir with a bouquet.